Okay, let's get started, I think. Some people are still munching outside, but welcome everybody to the formal hour of Grand Rounds. Thank you very much, everyone, for coming, but thank you very much, Jim, for being here, for spending the day with us, for already having given us a lovely talk. Dr. Bernat is Professor of Medicine and Neurology at Dartmouth. He is the neuroethicist, having been the chair of the American Academy of Neurology Ethics, Law and Humanities Committee for many years, having written hundreds of articles and chapters on issues, ethical issues within neurology and medicine. And seems like I think his main interest within ethics is brain death, and that's what you're going to talk about today. So we're very pleased to have you. Thank you.
Let's try it again here. Okay. Thank you, Claire. My talk today is going to be about conceptual controversies and death determination, and it's usually ICU death determination, and most frequently in the context of organ donation. I'm going to first, mandatory disclosures. I think of these, the ones that are relevant are some activity that I've had through the Department of Health and Human Services on the HRSA panel on determining circulatory death, and the WHO committee that might be relevant to this, but I'll mention those when we get to those. My objectives are talking about three things: the brain determination of death, and I want to show that the validity of brain death does not depend on the integration rationale, which I'll describe. I want to talk about the circulatory respiratory determination of death and explain what I've referred to as the non-congruence between the biological concept of death and the medical determination of death, and that it's relevant to distinguish the permanent versus the irreversible cessation of circulatory respiratory functions. And I'll explain that later. And then talk a little bit about the dead donor rule and about whether it should be continued or abandoned. The talk today is going to be not so much about medical technical controversies. I'll mention a few of them, like, for example, in brain death, do we need one examination to determine brain death or two? It's going to be a more fundamental look at the conceptual ideas that underlie our concept of when someone is dead that are relevant to using either a brain or a circulatory death determination, and that only by grappling with those can we hope to achieve some degree of consensus on the medical technical issues. Now, these questions have been spurred by organ donation. That is, it forces us to be specific about when someone is dead, because the dead donor rule requires that the multi-organ donor first be dead and that we don't kill them by transplanting their organs. But despite the fact that they're linked to this practical activity, they should be coherent independently. That is, they should rise or fall on their own coherence and not be contingent on some instrumental benefit. And I'm going to talk about the brain determination of death, and I'm going to use these abbreviations, DBDD, in place of brain death, and the circulatory determination of death, or DCDD, which has been formerly known as non-heart-beating organ donation or donation after cardiac death. And I will point out that that's a misnomer, because death has always been determined by cessation of circulation, not heart function, although they usually go together, they don't always. And ironically, more active controversies now involve death determination in the circulatory than in the brain death. Those of you that want to read a little more about this, I wrote a review article in Nature Reviews Neurology about a year and a half ago that has this citation. Now, one way to look at this is that there's a difference in concepts of death and death determination, and I've somewhat arbitrarily divided them into three groups. The first one might call the biological or even the ontological, that death is irreversible by definition. People don't come back from being dead. If they come back, they weren't dead in the first place. And if the concept of death requires irreversibility as a biophilosophical concept, then the cessation of functions that leads to showing that that definition has been satisfied should also require irreversibility. The legal, looking at least in the United States, our death statutes and the Uniform Determination of Death Act, which I'll show you in a moment, stipulate that the cessation of functions must be irreversible, and it uses that term. But it has a little caveat at the end that it defers to medical standards. Medical practice, however, doesn't use irreversible, it uses permanent. Traditionally requires showing a permanent cessation of circulatory and respiratory functions. And in this paper in the Hastings Center report, a couple of years ago I said that there was therefore there was a difference in these. I'm going to come back to that. This is the Uniform Determination of Death Act. This was a model statute of death that was proposed in 1981 by the U.S. President's Commission for the Study of Ethical Medicine in ethical issues in medicine, biomedical, and behavioral research. And they wrote a book called Defining Death. It was the first of 10 books published by the President's Commission, and that was a commission that was initiated under the Carter administration, but all the publications were published during the Reagan administration. And this was the first of those books. And they, in the early brain death era, proposed that all states enact the Uniform Determination of Death Act, or UDDA. And it provides an individual who has sustained either one or two. There were two criteria: irreversible cessation of circulatory and respiratory functions, or irreversible cessation of all functions of the entire brain, including the brainstem, is dead, and a termination of death must be made in accordance with accepted medical standards. They took this model statute and through an organization called the National Commission of Uniform State Laws, tried to get it to be a law in every state. They succeeded partially. The UDDA, or a close relative, that is, maybe one or two words were changed here, but it was basically the same thing, has been the statute of death now in the majority of states in the United States. And all states have a statute that permits brain death determination. But this had these 2 points. And it raises the question of how the two are related to each other. And in a paper in the Annals of Internal Medicine with my colleagues at Dartmouth in 1981, we addressed that issue in a paper called On the Definition and Criterion of Death, and said that it was the neurological criterion that was the fundamental criterion, which has been called brain death. And that the circulatory respiratory criterion, which the UDDA allowed as an independent test for death, was valid because in the absence of CPR, it led to fulfilling the brain criterion. It was just one way of fulfilling the ultimate brain criterion. And we pointed out in that paper that if if there was some resuscitation and it protected the brain, then the person wasn't dead. And the brain criterion is used only in the presence of respiratory circulatory support. So this idea of brain death that was first brought out in the late 1950s and early 1960s, and in the Harvard Medical School Ad Hoc Committee's paper in JAMA in 1968, put it on the map, used the term brain death, not a very good term, is that irreversible cessation of all the brain's clinical functions, not activities, cellular activities, but clinical functions, constitutes human death. And it's a misleading but standard term. The concept has been accepted throughout society although studies have shown repeatedly that there's a lot of confusion, not only in the general public, but also among the medical field about what it means. And it's accepted better by physicians than families. And I'm sure many of you have the experience of families rejecting this or saying, how could he be dead? He's still warm, or there's, chest is going up and down with a ventilator, heart is still beating. That doesn't make sense. Whereas the circulatory death is accepted better by families than physicians. That is, as soon as the heart stops, most families, in my experience, say the person died. But physicians know that you might be able to resuscitate them. So that they want to wait a certain period of time after that before they're convinced that death has occurred. So that's sort of an interesting thing. The international review of this, your own Sarah Walzer has a very nice paper in neurology this year in which they did an electronic survey, and I'd encourage you all to read it if you haven't done so, in 91 countries. And her colleagues, Ilko Vedics from the Mayo Clinic and Claude Hempel from UCSF and David Greer, who's now at Yale, and others did this study of international acceptance of brain death and found a tremendous variability, not only in the testing, but the legal standards and so on. And that's true, but it is a worldwide thing. It's law in all states in this country, throughout the developed world, much of the developing world. And the critics for over 40 years, many of whom I've debated during that time, have not gained any traction with the public. And the evidence for that is that no laws in any jurisdiction have changed to reject brain death, nor have any practices changed by medical societies. There's a survey show misunderstanding. In a recent survey I just wanted to mention, published in this journal by a philosopher from Madrid, David Rodriguez Arias, found very interestingly, and colleagues, that that medical professionals claim that brain death is a more reliable test for death than circulatory tests for death, which I thought was really very interesting. Now, my colleagues at Dartmouth and I got into this question of when is a person dead, and we don't have time to go through this in detail today, but the analysis that we proposed was a sequential analysis that proceeds from the conceptual to the measurable, starting with the paradigm of death, that is, conditions that frame the analysis so that everybody's talking about the same thing. A definition making explicit its ordinary meaning when we use the term death, which is a non-technical common word. The criterion, a general measurable standard that can be put into a legal statute that shows the definition is fulfilled, and the tests that physicians devise and perform at the bedside to show that the criterion is fulfilled. And that even opponents of this generally concur that this sequential, logical type of analysis is a useful format to study it, and one of its virtues is that it pinpoints areas of disagreement. Some people disagree with elements of the paradigm, like things like we said that death is fundamentally a biological phenomenon, and there are people who hold that it's fundamentally a social phenomenon. And we said, life is a biological phenomenon, and therefore its cessation should be a biological phenomenon. And there are social factors about practices and beliefs, but what I say is that it pinpoints areas of argument. So what we came up with was that the definition is the irreversible cessation of the critical functions of the organism as a whole. And I'll mention what that is in a minute. Criterion is the irreversible cessation of function of a critical number of neurons of the hemispheres and brainstem, the so-called whole brain formulation, in contrast to the brain stem formulation accepted in the UK and a few other places, or the higher brain formulation where the thalamus and the cortex are what counts, not the brainstem, which some philosophers, lawyers, and a few physicians hold, but it's never been accepted by any medical society or jurisdiction. And the tests we know, the most recent American Academy of Neurology tests were published in Neurology in 2010, and the Motor Society Task Force in Children the following year. And the whole brain criterion as a criterion of death requires irreversible cessation of the functions both of the brainstem, thalamus, and hemispheres. And the higher brain formulation is very popular in academic circles, the brainstem in the UK. And as I said, it requires cessation of clinical functions, not neuronal activities. And it has certain advantages. One of them is the pathogenesis of, in most cases, of brain death caused by the common things with the traumatic brain injury, massive intracranial hemorrhage, particularly subarachnoid hemorrhage, hypoxic ischemic neuronal damage during cardiac arrest, in children, suffocation, and other things too, certainly malignant MCA infarction without hemicraniectomy, cause transtentorial herniation. But what happens is that whatever the primary assault is, the second thing happens with swelling, intracranial pressure rises until it exceeds mean arterial blood pressure. And in some cases, particularly in subarachnoid hemorrhage, where there's arterial bleeding, intracranial pressure exceeds arterial blood pressure. But it doesn't need to get that high. It's high enough if it exceeds mean arterial pressure because although during systole the blood goes forward a little, during diastole it goes backwards. And the so-called reverberating flow, which you can see very nicely on TCD ultrasound, is evidence that there's no net forward flow, and that's sufficient. So that you get a situation where the primary insult has led to a secondary problem where there's no intracranial blood flow and secondary destruction of neurons that were not killed in the first round of whatever it was. And it creates, in a way, a fail-safe mechanism to assure loss of brain clinical function, and it permits ancillary testing that I prefer, such as tests showing no intracranial blood flow that has to be done within the window when intracranial pressure is at its highest. Well, this little formulation that I propose is not accepted by everyone, and there have been a number of attacks on this, some of which I reviewed in that review article, and to which I've replied in that paper and others. And the attacks include the choice of the definition of death, although I think most people are okay with that. An imprecise correspondence between the definition and criterion, that is, the criterion of whole brain doesn't always satisfy the definition of organism as a whole, and Alan Shewmon from UCLA made that point. Perceived inadequacies of the whole brain criterion, or Winston Chong, a neurologist scholar at UCSF, wrote a very interesting paper stating that it's impossible to have any uniform definition of death. But that doesn't mean you can't have brain death as a concept, he said, but so sort of an interesting philosophical perspective. And the critiques can be listed, and we don't have time to go through them in detail, but Shewmon said that brain death is not what we mean by death, and that the integration rationale is inadequate because some of the integration in the system occurs outside the brain, for example, in the spinal cord, which is certainly true. Bob Veach from Georgetown has been an advocate of the higher brain formulation and still maintains that. Bob Troop from Boston Children's Hospital and Harvard Medical School feels that it should be uniformly rejected as an unnecessary anachronism that was practiced in an era when it was illegal to withdraw life-sustaining treatment. But now that it is, that can be done. An organ donation can be done by consent without the person being dead. Bob Taylor, a neurologist, palliative care doctor at Ohio State, has used the interesting analogy that it's a legal fiction, like legal blindness, that we all know it isn't really dead, but we want to do organ donation, so we all agree that this is a legal fiction that allows us to do that. A couple of philosophers have indicated there's more than one kind of death, death of the person versus death of the human organism. That's a popular philosophical position. And I mentioned Winston Chong, that there's no uniform definition. And Alan Shewmon, I don't want to spend too much time on this, talked about the inadequacy of the integration rationale, and the U.S. President's Council on Bioethics, and this was a council that was impaneled during the presidential term of Bill Clinton. I take that back. This council, this particular council, was George Bush. There was another council under Clinton, but this was the Bush one. Endorsed that and had a paper that was published, which Alan, and they provided an alternative rationale, which is the inability of the organism to conduct its self-preserving work, which is sort of an interesting idea. And he then shot back with a paper in the Journal of Medical Philosophy saying that that the new rationale had the same defect as the one that it replaced. And I think that we need greater refinement about the organism as whole to defend this criterion. And this is an old concept. It's a 100-year-old concept. And the famous early 20th century and late 19th century biologist Jacques Loeb, the father of Robert Loeb, the former legendary chairman of medicine at Columbia Presbyterian, who some of the older people may remember. Well, Jacques Loeb was he was at the Rockefeller then Institute, and then the University of Chicago as one of their biology professors, and he published a book called The Organism as a Whole, in which he put forward this idea that an organism he didn't use the term emergent properties, but the current biophilosophers that have studied this use those terms, that they're functions of the whole organism that are not subsumed in any of the parts of the organism, and it functions for the unity and the wholeness of the organism. And the idea here is the brain dead patient is dead because the organism as a whole is gone, even though the subsystems are still living by technological support. And this idea of emergent functions in Monner and Bunk's very good paper, The Foundations of Biophilosophy, they have a chapter on emergent functions. There's been quite a lot written about that. A function of a whole entity not present or reducible to any of its component parts. And that when you have ensembles of cells, tissues, and organs, it creates functions like consciousness, the most ineffable of the emergent functions of the brain, that can't be reduced to any one part, but spontaneously emerges when all the parts are operating together in their normal way. And studies have been done, like Stuart Kaufman from the Santa Fe Institute has done a number of studies about complex systems and can you predict these things, and they're hard to predict and understand solely by studying the components of an organism. But anyway, let's get away from that conceptual stuff, although I'm interested in it, I think it's important. The tests of death, once you agree on the definition of criterion, are cardiopulmonary ones in cases without ventilatory support, and the brain death ones when you have ventilator support. And they should have no false positives and as few false negatives as possible. And this is an illustration of the fears, particularly during the 19th century, of false positive death determination before doctors apparently were very good at it. And this was a painting that hangs in the Wiertz Museum in Brussels by the Belgian artist Antoine Wiertz, and premature burial. And it took place, it was a depiction taking place during the cholera epidemic that swept Europe in the mid-19th century, of a person declared dead and put in a coffin, ready to be buried, but he wasn't quite dead as it shows, and this was a fear. And this is a depiction of a device that was patented, and hundreds of thousands of these units were sold in the 19th century for people to be buried in, that had this bulb that would rest on the chest and attached to a pole and above ground. If the pole was seen to be going up and down with the excursion of the diaphragm with breathing, why, that would ring the bell and wave the flag. I don't know what happened when it got windy. A lot of digging up perhaps, but it was illustrative. And of course, some of the stories of Edgar Allan Poe, like the premature burial, also were depicting the fear that people have that we as doctors will incorrectly diagnose them dead. So not having false positive death determination is pretty important. goal. And we know the examination. I don't want to go through the details of this. And Ilko Vedix and his gang have a nice article about this in Neurology several years ago that the Academy uses as a standard. And the medical controversies that I just in this paper that I didn't want to get into today because we were talking more about the conceptual part. About, should there be one or two examinations? And there was that study that that Ilko cited that found that in 1,500 brain death determinations, the second examination didn't add anything to the first. But there were critics of that who wrote letters to Neurology afterwards criticizing the format of the study that were not really adequately addressed by the authors. And I know we can discuss some of the politics of that later, but it's still somewhat of an open question. And I might add that the pediatric requirements, when they were published a year later, even though the AAN for adult requirements changed theirs to one examination, the pediatric one requires two, and a lot of state laws still require two. So that's an unresolved controversy. The value of the so-called ancillary testing, like electrical testing, EEG and evoked potentials, or the blood flow testing showing absence of intracranial blood flow by radionuclide angiography or transcranial Doppler ultrasound, or some of the newer things like SPECT or MR perfusion or MR angiography or CTA, by that for that matter, haven't really been well validated, although there's reason to think that they would be quite good. The need for standardization, a number of studies showing that different institutions have different criteria, and I was told informally that even between University of Washington Medical Center and Harborview, there are slight differences in the brain death testing, and that's quite common around the whole country. What to do with therapeutic hypothermia in light of some of the cases that have been reported of people immediately rewarmed following therapeutic hypothermia for cardiac arrest and determined to be brain dead, who then started to regain function 24 to 48 hours later. None of those patients did very well, but the fact that it even occurred has led most of us to require a mandated interval after rewarming of 48 hours to make sure that there isn't going to be any improvement before they're declared brain dead. And I'd be interested to know whether you do that here. The failure to accept it by family members and how that's managed is interesting. Religious opposition, organ donation issues, and so on. There are lots of areas of controversy that I've discussed in this paper we don't have time to get to right now. What I do want to do is switch gears and go to this second part of this, which is the circulatory death controversies. And that might strike some of you as a little counterintuitive. That, well, wait a minute, what's controversial there? But let's go first through what the typical paradigm is for controlled donation after the circulatory determination of death. And this, of course, and I know you have protocols here, that the dying ICU patient on a ventilator, usually with severe brain damage but not brain dead, where the family requests cessation of life-sustaining treatment, what's done in every ICU, in every hospital across the country every day, according to the patient's preference, but the family requests organ donation, or there's evidence of first-person consent prior by the patient requesting to be an organ donor. And the protocol basically times the cessation of life-sustaining therapy with the readiness of the surgical team and the scrubbed and gowned, gloved in the OR to do this quickly. And this was the proceedings of a national conference. It was in Philadelphia in 2005. We published in the American Journal of Transplantation in 2006 that created some areas of consensus in controlled DCDD. There's also uncontrolled, which is practiced in Europe, where people have a sudden cardiac arrest in or outside the hospital. They collapse, CPR is done, CPR fails. They're put on some kind of a thumper, like an automated chest compression device, taken to the hospital and used as an organ donor. And this is practiced widely in Europe, particularly in Spain and France and a number of other countries. Not in the United States. There are no accepted protocols. There have been a couple of experimental ones that have not turned out well. And anybody interested in that, I'd be happy to talk about that later. But this uncontrolled doesn't occur currently in the United States or Canada. I forgot I have a slide about that. So in uncontrolled is practiced in Europe, yeah. And those people interested in this, and the Hastings Center report, Monjau and their team from NYU Medical Center had an experimental protocol of this funded by HRSA, a division of transplantation, who funds the experimental organ donation protocols. And they explained in this very nice paper and in a couple of other papers why this didn't work here. So what are the controversies in controlled? We're going to talk about controlled DCDD. The principal controversy is the organ donor dead at the moment the organ donor is declared dead? Or how long must you wait once circulation stops? Given the fact that the heart might be able to be resuscitated by CPR, even though everyone agrees the patient is DNR and is not going to be resuscitated. But if death is irreversible, yet it's possible to reverse it, then that doesn't compute. And many people are quite upset about this. Although there are lots of protocols around, they're still upset about it. So does it violate the death statute that requires irreversibility, or should the dead donor rule be suspended? And this is when I got involved in this to try to see about this. And I'm going to present my position about this. And I mentioned the UDDA or a variation is law in every state, that irreversibility is intrinsic to the concept of death, but the UDDA doesn't define what irreversible means. And the President's Commission that created the statute and the document defining death, which is the rationale for the statute, use the terms permanent and irreversible interchangeably. And Alex Capron, who is currently an endowed chair in law at USC Law School and has been a colleague for many, many years, was the chairman of the President's Commission and wrote the document essentially with his team, told me that they didn't distinguish that difference, which I'm going to show you, that distinction is very important. And so let's get to that. These are two words, and I have a paper in the Journal of Medical Philosophy about that these two words are often used synonymously but have an important distinction. And I quote the Oxford English Dictionary, second edition, that irreversible means cannot be undone. And it's irrevocable, it's absolute, and it's univocal. That is, it doesn't vary among examples. Whereas permanent means continuing without change, enduring. And it's equivocal rather than univocal. And it's contingent rather than absolute. It's contingent on not doing something. So for example, if someone stops breathing and they're not going to auto-resuscitate, and you're not going to try to start it, you can say that they've stopped breathing permanently, or there's a permanent cessation of respiration. Is it irreversible? Maybe, maybe not. How long does it take before permanent becomes irreversible? Nobody really knows, and how to prove it's irreversible. But I think you see that there's a distinction there. So in short, something has happened here. Let's go back. Irreversible means cannot reverse using available current technology. Permanent means will not reverse because it will not be restored, will not restore itself spontaneously, and we through intervention will not restore it. And I think you can see that if you look at it as Venn diagrams, that the set of permanently ceased functions encompasses those that cease irreversibly. And it rapidly yields irreversibility, but it's an earlier stage of irreversibility. Well, how would you determine that something is irreversible? There are a few ways. One is you can attempt to reverse it and show that that is impossible. Although with some of the current technologies, this has become very, very problematic. Maybe it is, I think, insufficient proof. Somebody failed CPR. It used to be said that's prima facie evidence that it was irreversible, because you tried to reverse it and you couldn't. Well, there have been these cases reported now. I've seen one reported in the Mayo Clinic proceedings and one in the New England Journal of Medicine of people who failed, young, healthy people that had a sudden MI, cardiac arrest, couldn't be resuscitated, were put on ECMO for 3 or 4 days until the stunned myocardium recovered and the heart started beating again. They were taken off of ECMO and had good neurological outcomes. And these are people that would have been declared dead in every hospital in the world on the basis of failure to resuscitate with optimal CPR. So it's getting pretty hard to know what's irreversible anymore. A second idea would be to await classical signs of death. If the person has rigor mortis or dependent lividity, you can be pretty sure they're dead. But that takes hours for that to occur. We'll wait a long enough interval without circulation, say an hour at normothermia, after which everyone would agree that it was irreversible. But these are unnecessary and undesirable. Now, if you look at the death determination currently done in controlled DCDD, it satisfies the permanent cessation. One can argue by analogy, well, how do we use the circulatory criterion in non-donation circumstances? One can imagine a patient admitted to the hospital with widely metastatic cancer who's on palliative care getting intravenous morphine, for example, as a DNR order, is expected to die. Heart stops beating. We know there will be no auto-resuscitation in such a circumstance. As soon as the resident sees the patient, assesses the absence of vital signs, are declared dead, no attempt is made to prove that it's irreversible. Permanent cessation in that circumstance is sufficient because permanent cessation is all that has ever been required for the circulatory criterion. It's never been required to prove that the cessation is irreversible. So that's the medical practice standard, and there is therefore what I called a non-congruence between the medical practice standard requiring permanent cessation and the biological and legal standard which uses the term irreversible cessation. And permanence leads to an earlier death declaration than irreversible standard. And it's used by physicians primarily for social and practical reasons. We don't want to wait an hour or two to prove that to be certain that it's irreversible. This widespread practice has not led to an outcry by the public, although it's probably not well known by the public. I had written a paper about this in 2006 initially in an ethics journal, and shall we say that there was not uniform agreement with this, and some of the critiques that came back about it were that death cannot be a contingent event that depends on physician action or inaction. It is a biological thing that is immune to physician action or inaction. Well, that's just not true. And it's particularly not true now that with these ECMO cases, where we have to make a decision. Is the patient who's failed CPR after cardiac arrest, are we going to put that patient on ECMO? First of all, does the institution even have access to ECMO? Is it reasonable to do that? Who should be an ECMO candidate? The whole concept of irreversibility in that context turns on physician decision-making. So that this idea that death can't be contingent is simply false.
Jim?
Yes?
Would you define ECMO bridge for those of us who aren't
is extracorporeal membrane oxygenation, and it's used primarily in children as a bridge leading from failure of lung and or heart function to lead used before transplantation. So it's kind of like a mini heart-lung machine, but it can be kept going for days or sometimes weeks, and can be veno-venous or veno-arterial. There are places like University of Michigan Medical Center, which has a big ECMO department that is using it, and many other indications, and there's a lot of interest in its use following failed CPR, and leading to these reported cases of good recovery after stunned myocardium in acute myocardial infarction in otherwise healthy young people who were chosen rather than someone who's got 3-vessel disease or many comorbidities or other things. They picked out these few people to try it on and ended up with good neurological outcomes, which is a stunning event. Stunning. And really forces us to rethink some of these things. So we have what might be called a brave new technological world where irreversibility no longer is a purely biological fact, but is based to some extent on physician volition. There's always been some volition. For example, if a CPR is ongoing, at some point, if it isn't working, the doctor in charge of it has to decide, okay, it's time to cease CPR based on futility or irreversibility or whatever you want to call it, failure to resuscitate, and to declare that the patient has irreversible cessation of circulation and therefore is dead. Well, it was shown in a wonderful, very interesting paper in The Lancet, which I guess I didn't cite today, but it is cited and discussed in this review paper, that looked at the question of duration of CPR, look just a medical record review, duration of CPR as a function of success of CPR. I don't know if any of you saw this. It had an editorial that went along with it. And what it basically showed was that the longer the CPR went on, the more people recovered, and they were more good recoveries. And the editorialist claimed, or stated, opinion, I suppose, that what the data meant to him was that some of the CPRs are abandoned too early and need to be done longer. So here's an example of how physician volition affects the concept of irreversibility, because we would assert irreversibility to suspend CPR effort in a failed CPR. So there are lots of examples of why this critique is not valid. An interesting paper was published in Critical Care Medicine in 2010 by Hornby and colleagues from McGill, looking at the question of what about auto-resuscitation. This is this idea that the heart that is stopped restarts on its own. And there have been these cases that have been reported in the literature and have been written about a lot, but they wanted to do a systematic review of these and figure out how does it occur, and whom does it occur, and why. So they got funding, and they reviewed every paper they could ever find about this phenomenon in as many languages as they could get translated. And they had criteria for accepting them. Some of the reports were so sketchy, they just said, no, we're not going to, they didn't meet the threshold to be included. And what they found was very interesting. And that was that in the context of planned withdrawal of life-sustaining therapy of people in an ICU, like occurs every day, that there were 0 cases, not a single case could they find, of auto-resuscitation to restored circulation. They did see cases of auto-resuscitation from asystole to pulseless electrical activity. So some idioventricular rhythm that doesn't generate a pulse, it doesn't generate a cardiac contraction. So that paper that I cited earlier from the Philadelphia meeting, one of the areas of consensus that the various people who attended that agreed on was that what counts is not that there's some activity in the heart's conducting system. What counts is there is a contraction. The heart is a pump. Its essential function is to pump. And if it isn't pumping, it isn't working. And the fact that there's little, you can record something over the SA node or the AV node, doesn't count for relevant heart function. So that auto-resuscitation only counts to restored circulation, and a patient in the emergency room with pulseless electrical activity, that counts as no circulation. So what they found was there were cases of auto-resuscitation to pulseless electrical activity that went up to 65 seconds, but 0 of them ever had a restored pulse or a cardiac contraction. Whereas the ones that they found that did have return of heart pumping were all failed CPR cases. That would be the equivalent of uncontrolled DCD, whereas this first group is the equivalent of controlled. So people that collapsed with a primary cardiac arrest who had CPR, the CPR failed, they were asystolic, were declared dead. There were a number of them with good evidence of restoring circulation up to 7 minutes later. Excuse me, a lot of reasons for that, including things like auto-PEEP, this idea of lung hyperinflation occurring during the resuscitation and impairing the venous return of the heart, and so on. People have studied these things, and there are reasons for it. Some delayed effective drugs. But whatever it is relevant only for uncontrolled DCDD and not for controlled DCDD. So that has to do with how long we have to wait. So looking at this question, the original question as posed, are people dead at the moment that they're declared dead, which according to the Institute of Medicine's guidelines is 5 minutes, and we and most other people have used the 5-minute rule, which I think is used here. That at 5 minutes of asystole or pulseless electrical activity and no respiration, that we can say that these functions are lost permanently because auto-resuscitation will not occur and CPR will not be performed. So that one needs to prove that there is loss there's an interesting story. I don't have time to tell you the details, but after the 2 cases were published in the New England Journal from the Denver Children's Hospital of pediatric heart DCDD, which created a firestorm of controversy, and several of us wrote little pieces in the New England Journal on the perspective thing, and I had one in there about it, and Bob Veach had one in there. They knew it was very controversial, and they wanted to, the editors of the New England Journal wanted to anticipate it by allowing some editorialization, or at least opinion, in there. And one of the things that I said in my opinion piece was that part of the problem is that all the different hospitals have different criteria. And how can you make any sense out of all this? Because each hospital that does DCDD formulates their own protocol, and that protocol defines death. And although the IOM did say that they recommended 5 minutes, not everybody goes along with that, and that we needed some uniformity. So I got a call from HRSA a couple of months later, or about a month later, saying, yeah, we think that's a good idea, and we'd like to put a committee together, and would you chair the committee? So we studied this and published a paper in Critical Care Medicine back in 2010, and we recommended that this first part, and then, but that it was the difference between declaring death for organ donors and non-donors. It was much more consequential for organ donors about exactly what the moment was. So we needed to prove that they had no blood flow, and palpating a pulse was not sufficient because hypotension you can lose a pulse. So we recommended doing either blood flow by intraarterial catheter, which is very simple, or by Doppler, or the alternative was what we do in our emergency room in PEA cases is portable cardiac echo for opening and closing the aortic valve, which is very easy and reliable. And that we preferred the 5-minute rule, although 2 was probably enough. So that's what we said about it. And then this dead donor rule, I think we want to maintain. My time is almost up, so I'm going to just skip that part and say why I think that we should not abandon the dead donor rule. And it's mostly because it jeopardizes confidence of the public. The public wants to be sure that the organ donors are dead. There have been several examples of public fear. A BBC Panorama program in 1980 on brain death that claimed that the patients in UK were not dead and the doctors were declaring them. It led to a huge drop in organ donation rates that lasted for almost a decade after that was run. And then the 60 Minutes Cleveland Clinic expose, a better term for it, I think, having watched it, was hatchet job. A very unfair, biased thing on them just even considering a DCDD protocol by their ethics committee discussion, and someone approached the prosecutor in Cuyahoga County and went after them, and it was terrible. But it led to a lot of people turning in their organ donor cards. So I want to just end by the conclusions about the conceptual part of this, that there is a non-congruence between the biological and medical approaches, where the medical approach turns on it turns on the distinction between the permanent cessation and the irreversible cessation. And so the answer as to whether the donors are dead is it depends. If you're doing it by a purely biological approach, then an argument can be made that they're not dead. But the medical practice approach requires only the permanent cessation, and therefore they are dead by medical standards. And the legal standard, remember the UDDA at the bottom said that although they used the term irreversibility without defining it, they said that death determination must be conducted in accordance with accepted medical standards. And the accepted medical standards are very clearly using the permanent standard. So I think that there's legal support as well as medical practice support. So we can say that the donors are dead at the time of donation. So no by the strict biological standard, but yes by normative practices, and yes by the statute, because it provides in accordance with accepted medical standards. So I'm going to end there, and thank you for your attention, and we have a little bit of time for questions. Yes?
I'm really baffled why the whole definition is totally focused on death and not on what is meaningful life.
For organ donation, you mean, or for what? You mean why aren't people buried who have...
Well, it seems that death is defined without any context. So why can't life then be defined as without a context? Because it's quite different for a person who drops dead in the Cascades during a hike, or a person who drops dead here in the medical center and a doctor can attend to him. So the context plays a huge role into what the eventual outcome will be.
Well, that's certain. So the question is, the point is that the context is relevant to the outcome. I agree with that, but we're talking about the definition of when someone can be declared dead, as opposed to what you would do with them to try to save them or not save them.
That's
So,
a utilitarian question that needs to be addressed by society.
well, I agree it does, but it's a different question. It's a different question than the one that I've addressed here. It's a very relevant question, but it's not the same question. Yes?
I was curious if we don't think about offending the public or being ethical, just thinking from an organ quality standpoint, we need more organs to save more lives. Is waiting 5 minutes okay? How does that affect organs?
So say that a little
Oh,
bit.
the waiting 5 minutes
Oh.
after circulatory arrest.
Yeah.
How does that affect organ quality?
Right. So the question is, there's innate tension between wanting to wait longer to be sure they're really dead, but not waiting so long that it renders the organs unsuitable by hypoxic ischemic disruption. And that's certainly true. So the surgeons, the transplant surgeons, would want to do it as quickly as possible to maximize the health of the transplanted organ, understandably. But the critical care staff would want to make sure that there wasn't an incorrect determination of death. So I think that the 5-minute rule by the IOM came at a time before the data on auto-resuscitation was clarified. But even now that it is clarified, the N of it remains very small. And when I know enough about statistics that when there's a small N, the confidence interval is not very good. And when the confidence interval is not very good, then you want to be more conservative in the delineation because you don't want to make a mistake. So I've advocated for maintaining the 5-minute rule, but there are ways to accelerate getting the patient to the OR. We still do our death determinations in the ICU, but the distance from our ICU to the OR is very short distance. So they can go right over there, and everything's set. So there's very little time wasted there. I know in a number of hospitals, a colleague at the Mass General, for example, they've moved theirs to a room adjacent to the operating room so that they are almost in the OR at the time, and they've eliminated that. Our OR nurses vigorously took exception to that when it was suggested. They don't want any of that to go on in their operating room. Because they told me, we save lives, we don't take lives, or some slogan like that. So, okay, that was their way of looking at it. But, I think there are ways to try to, not to shorten the 5 minutes, but to shorten the time after the 5 minutes before the organs are taken out. And then, of course, there are things like putting the dead donor on ECMO, which our group, I didn't have time to go through all of the, thank you for getting those questions up. I forgot to do that. Putting the dead donor on ECMO, which our HRSA panel said, no, do not do that. Because if you do that, the brain can get perfused. And if the brain gets perfused, then you've destroyed the linkage between loss of circulation and brain function, and the whole validity of the idea of using permanent cessation of circulation disappears when you restore circulation. So do not do that. Now, some of the surgeons have responded, the group at the University of Michigan, for example, inserts a thoracic aortic occlusion balloon, which they inflate, and it's right about here, and it blocks all blood flow north so that there's no heart or brain perfusion. So they say. They haven't really tested it to see if it works. So, anyway, Jim?
Jim, part of resistance to even looking at things conceptually with the kind of rigor that we want to look at them, I think, is the yuck factor.
The yuck factor?
Yeah, which I think we have to kind of deal with. I mean, when these protocols for organ donation after cardiac death came out, Renee Fox published in that first Kennedy Center thing, she entitled her paper, and this is a woman who was a social worker who worked with Starzl at the birth of solid organ donation. she entitled her paper An Ignoble Form of Cannibalism. And one of the problems with listening to the conversation, you can imagine from a layperson's point of view, or maybe even Alan Shewmon's or somebody, that hearing a discussion in which death is being orchestrated in the way in which it's being orchestrated, you use the word time, but other people could look at it and say we are orchestrating death and that it's being motivated. That death becomes a motivated act for the purpose of organ donation. Sure. Or organ retrieval, organ harvesting. And I think that that's a huge issue, which we make it's a mistake for us not to know.
So for those of you who couldn't hear it, Jim points out that the linkage between the reasons for doing this death determination clarification is principally the instrumental goal of organ donation, and that having the linkage in that way leads to the presumption that there's a causal linkage, that the reason you're doing A is because you want B. And there's a certain truth to that, isn't there? That, I mean, why do we do brain death determinations now? In an era when we can just discontinue life-sustaining treatment long before people reach the point of being brain dead. And it is done, and of course the studies have shown there are fewer brain death determinations now than there were 10 years ago for the very reason that it's common to discontinue life-sustaining therapy earlier in the course of their illness when it's clear that the prognosis is terrible, and it's led to fewer brain dead donors. So most of the brain death determinations now are done for the purposes of organ donation. And the circulatory death is done when it's done because of organ donation. If someone is not an organ donor and a decision is made to allow them to die in the ICU, the exact time of death is inconsequential. And whoever writes the death certificate makes up some time. I don't know exactly what the time is, probably varies by the individual. Nobody cares because it really doesn't matter. I mean, the day maybe matters, roughly the time, a little bit, but that sort of precision that is being required is clearly the product of organ donation. So the linkage, even though we try to pretend it doesn't exist, you're quite right, it does. And I think it's led some physicians to be very squeamish about controlled DC. You're one of them?
No, it's also...
we have doctors in our medical center, particularly in the PICU, who are very squeamish about having children. And they've said to me, the reason they are is that they worry, they're very caring people, it's wonderful doctors. They worry that the knowledge that the kid could be an organ donor, they worry that subconsciously that colors their conversations with the parents and the families in such a way that it would encourage them to do that. And as long as the possibility exists, there's no technical solution to that problem.
And the purpose of the Pittsburgh Protocol, which forbade conversation being initiated by the physicians, was exactly because it was motivated by that sentiment.
Yeah.
It was, I mean, so that it's always been that way. But the other upshot of this is that it also opens the door to people like Crew and Cochrane who say, well, because it's, it is, because we really are orchestrating death no matter what. We can just toss out the dead donor rule and just let if we were being honest about what we do, then we really wouldn't need the dead donor rule.
No.
From that conceptual.
Right. I've taken everybody past the time, so thank you all for your attention. I'll stick around for a few minutes. Thank you for listening to the stuff that I find interesting.